I'm Kevin Frankish. Thanks so much for taking this time with me here on the Mental Health Podcast. We start a new feature today. It's called In Focus, a chance for us to zero in on certain mental health issues or disorders. And our first In Focus is bipolar. 86-year-old Pat Taylor has just written a book, Up, Then Down, Then, My Long Journey Through Bipolar Disorder. The thing is, though, that Pat, who I mentioned was 86, didn't find out she's been living with bipolar since she was a teenager until just a few years ago. That's because bipolar, the term bipolar, was not coined until the mid-50s and was not accepted into the medical books until the 1990s. We're going to be talking with Pat about her journey with bipolar, and we're also going to be talking to a medical expert on what the latest is on this disorder and what we should know about. In Focus, Bipolar, right now on the Mental Health Podcast. Hi, Pat. Thanks so much for joining me.
I'm happy to join. I'm excited about it.
This is quite an interesting book. I want to read something from the book's description, and it talks about what had happened after your mother passed away when you were only 14 years old. We're going to discuss that in just a moment. So we're going back to August 9th, 1953. Pat was in and out of hospitals, specifically psych wards, doctor after doctor, diagnosis after diagnosis. Nothing seemed to have a lasting positive effect. 38 years after her mother's death, 38 years, Pat finally received the correct diagnosis, and that was bipolar. That was 1991. You had to live with this, not knowing exactly what it was for so long, didn't you?
Yes, I didn't know what it was. And they diagnosed it first as depression, but I didn't even understand depression before I got my diagnosis for depression, which was the wrong one. I thought that I was evil, that there was something bad about me that caused me to feel so bad and be separated from people.
How long did you live with that feeling that you were evil?
About 20 years.
Wow. So that's got to add to the stigma around what was happening in your life. Meantime, you were having some manic episodes, but they chalked that up to schizophrenia.
They didn't really know what it was. They just thought I had depression. And that was when I saw my psychiatrist. For the first time, I saw my psychiatrist when I was about 45.
1991 is when you were finally diagnosed.
Yeah, 91. I was 42 then when it happened.
Do you
When I
remember?
finally had a diagnosis.
So where were you when you got that diagnosis, and can you walk us through how you felt at that time?
I got a new family doctor, and after seeing me for a couple of months, she said, "You're depressed. I want you to see someone." And I thought, how do you know I feel bad? Nobody has ever noticed before. And since she noticed and sent me to a psychiatrist, it was working things out with the psychiatrist that made me feel a lot better, knowing I had something. I wasn't evil, and that took quite a while with the psychiatrist. When I first went to see her, I sat on the edge of my chair. I just was so anxious that I wanted to jump out of the room. It took quite a while before I was comfortable with her.
And so when you heard that word, bipolar,
Mm.
what was that like?
Well, when I saw the psychiatrist, she diagnosed me with depression,
Yeah.
but um, it wasn't till a few years later. I saw her in about 84, and it was a few years later that I was at the hospital at the Clark, and I showed signs of bipolar. My manic episodes are not that bad, so it wouldn't be something I really discuss with the psychiatrist because I thought I was just out of control, and I didn't realize it. But when they diagnosed me with bipolar disorder, that meant I got the right medication. Because when I was diagnosed with depression, I was getting the wrong medications for bipolar disorder.
And I mean, when you get the wrong medication, it can actually worsen the symptoms. Is that what had
Mhm.
happened with you?
It it didn't. I don't know whether it worsened the symptoms. The symptoms just kept getting worse and worse. So maybe it did, but it didn't help.
Mm-hmm.
The medication didn't help. I had depression after I was in the hospital again and again and again. And it wasn't until I had um, shock treatment that the bipolar really showed.
Mm-hmm. Shock treatment.
And
Tell me about that.
well, I don't think shock treatment is as bad as someone worry about. I
Yeah, we use it to this day. It's not nearly what you would see in the old black and white movies. It's actually quite effective and quite safe today. But
yes.
but you're actually, almost like forcing your brain to rewire or to react.
Mm.
What is that like?
Well, I let's see. I would come out of the treatment not remembering what had happened, and the treatment itself, I was taken down without having any breakfast to the um, shock treatment area, and uh, they put me under for a little bit, just for a few minutes, and then I got the shock treatment, and then that was it. But it tired me out. But all day I was exhausted.
This
Uh,
is
I think it's I think it's a very good treatment. It's used usually as a last resort,
mhm.
and I've seen people when I've been on the unit just change when they had the shock treatment. People that couldn't didn't respond. I responded for the first dose. I did not respond for the next 15 doses.
Yeah.
So when it first happened, I thought, oh, I'm better. For the first time in my life, I felt I'm better,
Mhm.
but it didn't last.
For the first time in my life, that's interesting that you say that.
Mhm.
There is so much coming down on you since you were a
Mhm.
14-year-old girl, and things got pretty intense. How intense did things get for you through life? Essentially, I don't want to say it, but I mean, how bad did things get?
It's so bad that when my children were little, I was ready to commit suicide. I had the razor blade. I was sitting in the bathroom. And I only didn't do anything because my children came and were banging on the door of the bathroom. And then I said to myself, I can't do this to them. And I went out of the bathroom, put things away, went out of the bathroom, and went to play with them and said, I will never do that again until they're grown, and then I will take my life.
And I'm so glad that you are still here.
Yes, there have been a few times, but I'm good now at telling my husband when things are getting bad or calling my psychiatrist.
Why did you
I
write
have a
this?
very good psychiatrist.
Why did you write this book?
I wanted people to understand mental illness. I wanted people to feel more compassionate to the mentally ill. And I wanted people to be able to, I wanted to fight the stigma.
Thank goodness for people like you. It because that is, you not only had to fight what was happening with your mental health, you had to fight that stigma too. So it must have been so difficult, especially when we're talking about the 50s and the 60s, to fight that stigma.
That stigma was very bad then. That's one of the reasons I never told anybody how bad I felt for so long and didn't want anybody to know. I guess I was just afraid of what would happen.
What would happen with people ostracizing you or perhaps even
Yeah,
making fun of you, things like that.
yes.
But you have gone on to live a good long life.
Yes, very.
And so what is, you're now 86, right, Pat?
Yes, I am.
So what is it like for an 86-year-old living with bipolar?
Well, the depression is still a problem. And in about February, I started to go down. And I know myself well enough to know that just wasn't a little blip. It was going to go down to a very bad depression. So I called my doctor, my psychiatrist, and he prescribed another medication for me. And I was so happy it worked. And then I got muscle pains, and I couldn't take that medication. So we had to find another one. And Dr. Works well with me. Um, I feel we're partners, and we worked out one other of my medications to up it a little bit, and it worked. I didn't go down to the depths. I um, I feel right now, I feel just fine. I don't know what tomorrow will be, but I feel just fine.
What message would you have for people who are newly diagnosed with bipolar or people living with bipolar right now? Perhaps people who are also thinking that maybe they don't want to be here anymore.
It's a distorted view when you don't want to be here anymore. Your mind is not thinking properly. It takes a bit to convince me that I am not, I don't have this all the time. And so I would say it's it's only short term. This, you will feel better, and if you get help, you'll feel better sooner.
In fact, you say that in your book very emphatically. Get help, get help, get help.
Yes. I think if I'd have been treated with the right medications when I was 20 or before, my bipolar wouldn't have got so bad. But there
Well,
weren't the medications then anyway.
it's a powerful story because it's told obviously from the heart. And I think people will really be rewarded by reading this to realize that there are others out there who are living this way. I mean, everybody's story is different, but there is that common denominator of the bipolar and how it changes and impacts your life, isn't there?
Yes. It's your life just changes.
Pat, thank you very much for sharing your story, for being so candid about it.
Can I show my?
Yes. Oh no, and I'm showing it too. I want people to pick this up. Up, then down, then. My long journey through bipolar disorder. Where can people get this, Pat?
They can get it from me if they email me $15 to Pat's memoir.
I don't. You know what? I'm putting it. I am going to put that
hotmail.com.
At hotmail.com. Pat's memoir at hotmail.com, and we're going to mention that at the end of the episode as well. So I encourage people to think about this, and it really is something we don't understand very much, but that doesn't mean that we have to create that stigma. Pat, thank you so much for not only writing this book, but for telling your story with me here on the Mental Health Podcast.
You're welcome. I'm really glad to be able to share it.
I'm joined now by Dr. Amanda Abate. She is an inpatient psychiatrist at Ontario Shores Centre for Mental Health Sciences. Hi, doctor. How are you?
I'm well. How are you doing, Kevin?
I am doing well. So let's talk about bipolar now, because it is becoming a term we're hearing more and more about. So my first question is it because we're seeing more cases, or they're just being better diagnosed?
So, in terms of incidence of bipolar disorder, it's fairly stable at about 0.6% for bipolar type 1 and 0.4% for bipolar type 2. And we can talk about the differences between those at a later time. But I think, we're seeing a lot more understanding and appreciation of mental health in the community and more awareness. So I think there is a better understanding, and people are coming in more frequently for assessment. But the rates are fairly stable, but I think our dialogue around bipolar disorder has increased in other mental health disorders.
Now, what's fascinating about the case we just heard with Pat is that bipolar was actually, I did some reading on this, bipolar was actually called manic depression until about the 50s, when they started to actually understand it a bit more. But it really wasn't an accepted psychiatric term until the 80s. So this is not a new illness, but it's a newly named illness. So there's a lot of misunderstanding and confusion. And for someone like Pat to be misdiagnosed so often and so young, it's got to add to the stigma.
Absolutely. And that is a really common situation. And we have to note that a lot of mental health disorders are diagnosed phenomenologically, which means what symptoms are people presenting with. There's not a blood test or a brain scan that's going to tell us what exactly a person is dealing with. And also our manual that we used called the DSM basically is reassessed over time. And as we have better understanding of different illnesses, the diagnostic criteria might change or the name might change. And so that can account for things like Pat dealing with a diagnosis of manic depression before, and now it being referred to as bipolar disorder. The other thing, that relates to stigma a little bit or lack of understanding is that now that we have the term bipolar, a lot of it can sometimes be used colloquially, often like in situations where people might say, I'm bipolar because their mood changes minute to minute, or they have a strong sense of their mood from moment to moment. Bipolar itself has a very...
by simply saying something out of turn. It's just, I guess, similar to saying, "Oh, I'm crazy."
Yes, exactly.
So I'm so bipolar. You're so schizoid. We hear that from people as well.
Yes.
And I think that I'm glad you brought that up, because that too adds to the stigma around this illness, doesn't it?
Absolutely. And I think there's also a lot of misunderstanding of how it develops, and that also can add to stigma. So certainly better education as we move forward, not only for patients and families, but for the general population, is really essential, so that we really have an understanding of what someone's going through. And especially, with bipolar, we have two phases of illness, the depressive side and the manic side or hypomanic side. And, in both phases, but most often in mania, people will behave in a way that is completely out of character. And so it can cause a lot of negative repercussions in one's life. And when people around them don't have an understanding of what's going on, it can lead to a lot of difficulty for the person dealing with it and those around them that love and care for them.
Yeah, and I can speak to that because someone close to me was diagnosed with it, and it's like you said, it came out of nowhere. The person was out of character, and I think the scariest part is not being familiar. I've heard the term bipolar. I didn't know what the heck it was, what the prognosis was. Is this the way this person I love, I know, is going to be for the rest of their life? So there's a lot of questions and fear around this diagnosis.
Absolutely. And maybe if I can go through kind of what we're talking about specifically when we're talking about bipolar disorder. Okay. So like I said, there are depressive components to the depressive episodes as part of the illness, and hypomanic or manic episodes. So when we're talking about depression, we're talking about, low mood, lack of interest in things that used to bring them joy, associated symptoms like changes to sleep patterns, appetite, concentration, energy, and sometimes feelings of excessive guilt, and at times also suicidal thoughts, not for everyone, but for some. And then for mania, we're talking about an episode where someone's having an extended period. And that's something I really want to hit home. We're not talking about hours to hours. We're talking about at least 1 week for mania, but it could be longer, of extreme, elevated or expansive mood and increased energy, very excessive energy, more so than they've kind of experienced otherwise in their life. And then associated symptoms with that. And again, in that case, it might be grandiosity. So kind of having an overly high view of themselves. There can be irritability, fast speech, and increase in activity, and also engaging in activities they wouldn't normally, that have a high degree of consequence. So, for example, someone who might be a penny pincher is suddenly taking out loans for tens of thousands of dollars that they can't pay back. And so when we're talking about bipolar disorder, we're seeing these distinct periods of illness. And then in between those episodes, we can see what we call euthymia, or when the mood is not depressed or manic.
I guess there's a big question too about, well, what causes it? Is it environmental? Is it genetic? I know in our case, we had heard that it quite possibly had to do with cannabis. So tell me about the causes of this.
Yes. So, like I was saying, with most mental health disorders, we don't have a specific cause that's known, and there's not going to be a blood test or a brain scan that's going to let us know that this is what someone is going through. Based on the history, there are some things we know. So, for example, the risk in the general population is about 1%. But if someone has a first degree relative with bipolar disorder, their risk of developing bipolar disorder increases by 5 to 10%. So we know that there is likely a genetic component, but it's not that it's likely one gene, but perhaps a number of smaller genes, genes with smaller effect working in combination, likely with presentation of interplay with environmental factors. So another risk factor that's known is presence of adverse childhood events. So things like abuse that people might have experienced might be a cause, or other stressors. And then other factors that we don't know. And then in terms of cannabis, we don't necessarily think it causes the bipolar disorder, but it can both kind of cause earlier presentation of illness if someone is predisposed, or exacerbate symptoms later on in the illness. And I want to say as well, though, a lot of families or loved ones will want to know, what could I have done differently to prevent this? Was it this? Was it that? And at the end of the day, we don't know. And there are plenty of people that develop bipolar disorder that have none of those risk factors. So that can be frustrating, but also to say that, there's no one thing, and that people shouldn't take it on themselves as feeling blame for illnesses like this developing.
And is there any, I hesitate to use the word danger, but if someone is going through a manic episode, are they a different person? Would they do something perhaps to someone they loved, such as violence or anything like that they normally wouldn't do?
So it is possible. Now, I really want to emphasize there's a wide variety of presentations of all mental health disorders. But with mania specifically, we're talking about someone that part of the criteria is that they're having significant social and functional impairment, or potentially are requiring hospitalization or requiring hospitalization. So these are people that, they are presenting in a completely different way than they would respond if they weren't in a manic episode. And so there can be times where, again, with that grandiosity, feeling on top of the world, or if at times they're also exhibiting psychotic symptoms, they may in fact, get into a position where they might be violent towards other people. Now, in general, I do also want to emphasize that more often than not, those with mental illness are more likely to be victims of assault than to be one to assault others. So it is a risk factor to consider, but it's important not to consider that, not to think that everyone that has a mental illness is at risk to other people, because that's not always the case.
Okay, so let's talk about medication, because of course that's one of the main ways that bipolar is treated. But there's a big debate that always goes on about medications, how effective they are. And sometimes it's a hard time trying to find something that will fit a person's genetics and their certain case. So tell me a little bit about drugs and what people should know about them.
Yeah, absolutely. So generally, when we're looking at treatment for bipolar disorder, I'll speak to mania specifically, and we can talk about depression as well in the context of bipolar disorder. But for mania or hypomania, the two main classes of drugs that we tend to use are mood stabilizers. So exactly as they sound, medications to help stabilize the mood. And then the other class that we often use are called antipsychotic medications. Now, it's a bit of a misnomer because they're also providing mood stabilizing benefits. And really, the classification of antipsychotics is that they're acting on dopamine and limiting dopamine release. So when we're talking about it, those are the two classes. But just to say that when we're talking about antipsychotics, it's not necessarily because someone is presenting with psychosis at the time. The other thing to note is, again, similar to diagnosis and not having a series of tests to tell us what's going to be the right or what diagnosis someone has. We also don't have tests, unfortunately, to tell us that someone will respond specifically to this medication. Now, there's look into that. There's research into that about potential genetic testing that could tell us how someone metabolizes certain medications. But we really don't know at this point what medication is going to work for someone.
I've heard of the DNA testing and that, but that's still not 100%.
Absolutely not. So it's in fact not even really telling us, are they going to respond to it so much as it tells us, okay, do you metabolize this medication quickly? And so you might need higher doses, or are you a slower metabolizer and you need lower doses? So it's telling us that information at this point. The other thing I want to speak to is that I will not for a second pretend these medications don't have side effects. They absolutely do. And, what's important is to have a dialogue with your prescriber about what you're experiencing, and to not necessarily throw away the idea of medication because of the side effects, because you might start on one medication, it might not work for you, or it might be effective in treating your symptoms, but you're having bothersome side effects. And you might then decide, well, I don't want to take this. But there may be a possibility of trying another medication that might have similar benefit and not have side effects, or there might be other interventions we can do to mitigate the side effects. We don't want anyone to be on a medication where the risk outweighs the benefit. We want someone to be on a medication that works for them. I'm not going to say that there's going to be, there's going to be no presence of side effects, but I'm going to say that by having a dialogue with your team about what you're experiencing, you're more able to work with your team to find something that works for you.
And it can be a while before someone gets treatment. Unfortunately, that's the way it is these days. Mm-hmm. What can people do in the meantime while they're waiting for that treatment?
Absolutely. So, it depends on the situation. If it's that someone is, for example, acutely manic and there is a risk for themselves or others, or you're worried about that, speaking to the person to seek immediate medical attention. There's ways to work with the justice of the peace, or say family doctors or emergency doctors to kind of mandate coming into hospital and being assessed. If it's more that it's the person, it's not an acute risk and you're wanting to talk to the person or try to get them to come in to seek treatment, it may be connecting them with resources they feel safe and familiar with, like say their family doctor. Community organizations can be really helpful, like the Canadian Mental Health Association has a lot of resources for families. Or, here at Ontario Shores, we have the Family Resource Center, which is a fantastic resource for our families. And also to say, it's there may be a point where the patient themselves is noticing, I need help. Maybe they're in a depressive episode. Generally, people in hypomania or mania don't necessarily notice that they need help in the same way. But if it is the case that they're noticing they're going through these cycles, they're depressed, seeking out medical support, the first resource would be their family doctor if they're able to reach out. And I know that's hard. A lot of people don't have family doctors too. But again, also reaching out to these organizations like the CMHA, they can help navigate the process if you've never kind of engaged with the mental health system before.
All right. So much to know. And of course, I always say, knowledge is power. So research. There's a lot of resources available. I would suggest ontarioshores.ca, and we have a lot of information about bipolar there, as well as some links as well. Dr. Amanda Abate, inpatient psychiatrist at Ontario Shores Centre for Mental Health Sciences. Thanks so much for this time.
Thank you.
And I do want to thank my guest, Pat Taylor. Her book, Up Then, Down Then, My Long Journey Through Bipolar Disorder, is available at most places you buy your books, including Indigo Chapters and on Amazon. Thanks so much for joining me. Until next time, take care of yourself and take care of each other.